Hello and welcome to The Beat, a news and talk program brought to you by the Center for Community Media at Worcester State University. This introduction has been pre-recorded for future episodes due to the unforeseen circumstances that the pandemic may bring. We hope you enjoy this segment.
So I just want to start off by saying hello and thank you to Dr. Hirsh for joining us again on The Beat. Could you please tell our viewers what your positions are at UMass and for the City of Worcester?
Yeah, so I wear a lot of hats. my hat here at UMass is I'm a professor of surgery, and I'm also the assistant vice provost for health and wellness promotion. And then over at the city, I'm the medical director for the Division of Public Health, and I'm the chief medical pandemic information officer for the pandemic response for the city of Worcester.
Awesome. So communities have different concerns regarding COVID-19 positivity rates. With that being said, could you provide a quick snapshot of the COVID situation in Worcester right now?
Well, yes, the COVID epidemic seems to have abated over the last 5 weeks. We had, as you recall, a big surge in the late spring. Then the summer was a little less volatile. And then we had our surge that started kind of mid-November with all of the holiday travel around Thanksgiving. And it went right into the holiday travel for Christmas and New Year's. So we really maxed out the numbers of cases that we were experiencing in mid-January. The peak was just around Martin Luther King Day, and now we've seen a steady recession. It's been interesting because I think the overall death toll was higher in the first surge, but a lot of that was because we didn't know as much as we needed to know about the treatment modalities, and we unfortunately allowed a lot of the spread to happen in long-term care facilities where the elderly really got hit extremely hard. Second wave, we had better therapeutics because we had monoclonal antibodies and convalescent plasma. We knew about timing for administration of things like high-dose steroids. We understood more about not necessarily putting patients on the ventilator immediately when they came in with respiratory distress. There were other things we could do short of that actually kept them off the ventilator and out of trouble longer than if you intubated the patients right away. And all of those things in combination made the mortality less in the second surge. So now we're facing much lower case numbers, and that's a great thing. But there are some threats, and we can talk about those, that are very concerning to most of the virologists and the people in public health that I run in those circles with.
That's great. It's really nice to see them take that initiative in the city. So can you tell our viewers about the 2 vaccines that are available currently?
Right. So this is very exciting. You know, the first pandemic cases were kind of recorded just about this time in the United States a year ago. I think in retrospect that there may have been a few very early cases that were unrecognized in December of 2019. But by and large, most people say it was end of January that we first started seeing cases pop up on the West Coast. And then in our area, mid-February. But the official start of the pandemic for Worcester, we list as March 11th. So from that time when the virus was recognized, that's when Moderna, which is a company based in Cambridge, actually, and Pfizer started working on this vaccine. Now, there's a lot of misconceptions, Jill, about this vaccine because people think, oh, people cooked it up in a bathtub in March of 2020. the building blocks for the understanding of how these two vaccines work, which is, I'll explain in a second, was based on other pandemics that had been going through the previous 20 years. So there was a SARS outbreak in 2000. There was a MERS outbreak in 2003. There was a swine flu or H1N1 outbreak in 2009, an Ebola outbreak in 2014, a Zika outbreak in 2016. Each time there was one of these viral outbreaks, and almost all of them involved shifting of an animal kind of virus into the human. Scientists put their heads together and said, oh, we can figure out a way, instead of old type vaccines where you give a dead version of the virus to the patient and that stimulates their immune system, or you give a live version of the virus that's been kind of defanged, but could sometimes cause some viral symptoms when people got it. That's why you probably have friends who said, oh, I never take the flu shot because I always get sick. That kind of stuff is really part of where the vaccine hesitance comes from. This is a completely different kettle of fish. This is a piece of the viral mRNA, the messenger of the gene is actually attached to a fat globule that is injected into the muscle, and it finds its way into the muscle cells, and the muscle cells start producing a protein that sits on the outside of the virus. If you see those pictures of the coronavirus always, in the background while newscasts are going, it always looks like a beach ball with a bunch of spikes on the outside. And those spikes have a protein on them that's called the spike protein. And that's what these mRNA pieces are making your muscle produce, which then causes your body as an immune response to create antibodies to the spike protein and also charge up these special white blood cells called killer T cells that will attack anything that has this spike protein on it. So this is a very different pathophysiology, and it's not likely to make you sick because it's not giving you the virus. It's just giving you a little muscle ache because your muscle is definitely going to have some antibodies reacting to the spike protein production that's going on there. So the two that kind of passed muster through the FDA in very record time were Pfizer, which is a 2-dose vaccine separated by 3 weeks, and Moderna, which is a 2-dose vaccine separated by 4 weeks. And both of them give you about 95% immunity to the original COVID-19 strain that they were tested against. That's where some of the concern has now come, because all viruses mutate, and there are new strains now that are being called variants that have made an appearance. They started in Europe. There's one that's called the UK or London strain. There's one that was discovered in South Africa. There's one that's was discovered in Brazil. And like all viruses, unfortunately, unless you shut the world down, they're going to travel. And so now we have identified them on our shores, mostly the London strain first, the Brazilian strain not so much, and the South African strain not so much. Thus far, all evidence points to the two vaccines, Moderna and Pfizer, still being very effective against the London strain. It's unclear whether they are as effective against those other two strains I mentioned, South Africa and Brazil. And that's the threat. These three strains are more transmissible than the original strain, meaning when you inhale a droplet of them, they stick much more tenaciously to the lining of your lungs. And that's why they build up a higher viral load in your body. Um, so the London strain, for example, doubles its numbers every 7 to 10 days. So now we are really in a race to see whether we can vaccinate enough people so that this London strain does not find enough folk to attack. We're hoping that between the very large number of patients that have already had COVID and probably have some immunity from that, and the people that we're vaccinating, that hopefully we can win this race, but we could lose it. And if we lose it, what will happen is we'll start to see those hospitalizations, those death numbers start to go up in a third surge. And I think that would happen if it happens late April, early May.
Yeah, that's definitely really interesting. I know myself, I've heard a lot about the UK variant and how it could potentially even become the more dominant strain of COVID here in the US. So it is definitely something that's a little concerning. But getting back to the vaccine, where can people go to get vaccinated in Worcester?
That's another great question. So Worcester, the city of Worcester, stood up an emergency dispensing site, we call it EDS, at the Worcester Senior Center. That was the first place in Worcester where you could get the vaccine. If you were a citizen of Worcester or worked in Worcester, or any of the 5 towns around Worcester that are part of our Central Mass Regional Public Health Alliance. That's West Boylston, Holden, Grafton, Millbury, and Shrewsbury. And so because the governor set up a phase program where there was a prioritization done of who would be going first, phase 1 was first responders, such as firemen, policemen, paramedics, and EMTs, but also it expanded to include home health aides, visiting nurses, home nurses, folks that you wouldn't necessarily think of, like reservoir protection security agents, court officers. It really expanded quite a bit. And we took care of about 80% of that population at the senior center since we went into business January 11th. Phase 2 is a huge bucket, and it opened up 2 weeks ago. The first part of phase 2 that we had to attack were seniors 75 and older. And they present a lot of logistic problems because they're not as mobile. They take more time to get in and out of a center like that. And it's been a challenge. Fortunately, in the meantime, a deal was struck between a partnership of St. Vincent's Hospital as the clinical partner, Commonwealth Medicine, which is kind of like the logistics partner at UMass, and Worcester State University to use their very plush, relatively new gymnasium as a regional super site. And so whereas at our Worcester Senior Center, we're maxing out at about 500 vaccinations a day. Eventually, and the super site only stood up on February 16th, so it's very new. It will supposedly get up to about 2,500 to 3,000 doses a day. So those are the 2 main active sites here in Worcester. There are some pharmacies that are also standing up. There's a Walgreens in Holden. There's a CVS on Park Ave. There are pharmacies within some supermarkets that are going to be standing up. There's a big Y on May Street that is going to stand up one. These are coming up slowly as well. And then UMass itself is vaccinating its own patients over at the Mercantile Center, where they also have a Stop the Spread free COVID testing site. So right next to the testing site, you can get your vaccination. And the vaccine that most of us are giving out is Pfizer now. We also have given out some Moderna. And we're anxiously awaiting 2 other types of vaccines that are going to come onto the scene probably in middle to late March. There's a Johnson & Johnson version and an AstraZeneca version, both of which are exciting because they're one shot. The 2-shot thing is a complicated thing because you have to time when the person's getting their first shot, when they're going to come back for their second shot. And you have to make sure you can't give a Moderna second shot to a Pfizer person or vice versa. So there are a lot less moving parts with the Johnson & Johnson and AstraZeneca, but they are not as effective. They are probably only about 70% effective as opposed to 95% effective. So there's pluses and minuses to everything. But the object really is needles in arms. Needles in arms is the way that we can beat the variants and we can beat back this thing so we can get to what we call herd immunity.
So in your professional opinion, should anyone who's eligible get vaccinated for COVID-19?
Absolutely. I think the only exception would be someone who has demonstrated, severe anaphylactic reaction to vaccinations in the past. I think that's about the only contraindication. If you've had COVID, if you've actually had the infection, you have to wait at least 2 weeks after the last day you were symptomatic before you get it, because otherwise you might get an aggressive immune response. And now there's a lot of evidence that's mounting, and it's not official yet by the CDC, that if you've had COVID, you might only need 1 shot because you might have enough immunity just with 1. But yes, absolutely. The herd immunity we're looking for is that we get 80% of the country vaccinated. And if we had that, the virus would just not find enough people to infect in any meaningful way. And we'd have a way of moving on away from this crazy pandemic mitigation life that we've been living with, the 3 W's, wearing your mask, washing your hands, and watching your distance, staying away from congregate situations. So I think this is the best thing you can do for yourself and for your family. It's so much better to get vaccinated than to actually get the disease. The disease now, as we're seeing from the folks that got it in the first surge in the spring, causes some long-term illnesses. And we're not sure how long-term, or whether this is something that is going to be like a chronic thing like Lyme's disease is. It's so common in New York City, where they got really hit very hard, that one of their top hospitals there, Mount Sinai, has a special post-acute COVID syndrome, PACS center, where they've cataloged, some incredible stories of healthy people your age, Jill, that have, they were marathon runners before, and now they're having trouble walking a city block, or they were personal trainers and they can't carry a bag of groceries anymore because they can't lift. Manifestations of neurologic problems, kind of cognitive problems, heart problems, lung problems, muscle weakness, GI issues also. People just aren't able to tolerate certain foods anymore. So these are called the long haulers. And if we can avoid having a whole giant generation of long haulers by getting vaccine into their arms, that would be just the greatest, because otherwise this is going to really be a huge burden for a much longer time than just this vaccination process. This is going to go on for 40 or 50 years while these people sort out their various issues.
Thank you for watching this segment of The Beat. Please remember to like us on Facebook and follow us on Twitter and Instagram. We will see you next time.